Good afternoon, and actually for you, Dr. Aziz, you are in Arizona, so it's still the afternoon for you, and for us it's evening. So I am very pleased and honored to have you and Kristen on my show and to talk about Perioview. And with that in mind, I want to say a little bit about you. You are a periodontist that's been practicing since 2002 in Arizona, and you have a very flourished practice. And then you went into invention, and we will talk about what you have done and how far back it goes and all the good stuff. And you, Ms. Kristen, you are a hygienist for over 8 years. You did your studies here in New York, and you've been practicing, you're still practicing, and then you joined Dr. Aziz in his new venture. And with that, let's start talking about this venture. So, Dr. Aziz, tell me, how did you end up doing this?
Oh, very simple story. So as you said, I started my practice in 2002. Around 2010, 2011, I was introduced through my colleagues and my director, looked into laser therapy for periodontal disease. I looked into it, and like a lot of us, I took a leap of faith. I'm like, okay, let's try it. Like conceptually and all the literature-wise, we were like, I don't know, but I'm like, let's do it. Let's see what happens, right? So I got the laser, and I tried it, and after six to 9 months, I looked at my results, and it was not predictable. Sometimes it would work great, sometimes it didn't. And whenever it did not work great, I would go back and do osteosurgery, go back and fix, get the issues where we need to get it to. And whenever I would go back, there was always calculus left behind. There's always some sort of, disease products left there. So at that time, I kind of packed up the laser and put it in the closet, because I'm like, I'm not getting predictable results. And the amount of times I have to go back and retreat those areas was killing the business model. So put it in the closet, and then about a year or so later, I was at the AAP meeting and ran into John Kwan. And John, as many of you guys know, he had saved perioscopy and brought it back to life, and he was running the perioscopy. And as soon as I saw it, I'm like, that's it. That's the missing link. Because if you can see below the gums while we're cleaning out the root surface, and we can get all the stuff off, we will get more predictable result. I mean, it was split second to me in my head. And I bought the scope at that time. And initially, again, like all of us, we were very conservative. I bought one to see how it works and everything else. And it worked like amazing. And basically in the next year, I had 4 of them. And by 2018, 19, I had 6 of them, because I have 2 locations. I have a small practice. I have 2 locations, 4 ops each. And each of my hygienists had a scope on their own. And I would work out of 1 room, and the hygienist would work out of 3 rooms. So that's how I got into the scope, and I haven't looked back since then. But around 2020, like it got into my head. I'm like, all the TVs, all the monitors we have, they've all improved on quality, but the perioscope hadn't improved. It was still the same technology that it came out in 2010, 2011, I believe, and they hadn't made any advancement on it. So I went and talked to Zest, and they didn't want anything to do with it. They were like, whatever, just go away. So as people who have used the scope, once you go into it, you cannot go out, because that's the best way we feel like we can treat our patients. We get predictable results. They don't hate us because we're not cutting them open. and so I was like, I got to do something, because if I don't do it, if this ever goes out of business, or if they take it off the market, I don't want to practice. I don't want to do osteosurgery ever again. So I put my money where my mouth is, and a few years ago, I hired a few engineers and came up with Perioview and started from there. And Kristen came along. I think first 2-3 months, we started having a conversation, and from one thing led to the other, and she's incredible in what she does. So, that's my story.
Can you hear him?
No, I can't. Edgar, we can't hear you. I was trying to play with my mic. I thought it was on my side, Kristen.
Okay, okay, this is what
There
it
we
is.
go.
There
There
you
we
go.
go.
I'm sorry, I pressed the wrong button. So at least it looks natural. We didn't have to. So I said before, I remember that when the scope came, I told you the story,
Yeah.
and the scope. Before we get to you, Kristen, I wanna just because he started talking about the innovation that he did, and I remember the scope. As I told you, one of my friends had it. He was in
Yeah.
Seattle, and it was circular. It was limited. The quality was not great. So, can you, when Kristen came and visited me, I'm to the office and introduced me to the Perioview, which I was blown away with the field and all of that. But can we elaborate a little bit, either one of you, on what are the differences between the old technology and the innovation that you have introduced by hiring those engineers?
So the basic things comes out to is in the perioscope, there is a fiber scope, meaning the camera is at the base, and at the tip of the explorer, there are fiber optic fibers there. So as you can, in a 1 millimeter, they can get so many fibers, and that was limited the quality of the image.
Hmm.
To improve the quality, what we had to do was miniaturize the camera and move it to the tip of the explorer. So the camera with the fiber optic light, it measures 1 millimeter. So that's at the tip. And so now, because we can do that, we have increased the resolution 16 times. And for magnification, has gone from about 25, 30x to 100x.
Wow.
And so that's the resolution on the screen that you see. And so going from a 6-inch circular motion in the perioscope, now we have 11 by 11 inch a square.
So it went from circular to square. That's the first thing that I paid attention to.
Yeah.
And then you moved the fiber all the way to the tip of the probe that you insert inside the gingival tissue on the sulcus or the pocket.
Yeah, the
And
camera's at the tip of it, yes.
tip. So these are the two major, and the magnification you went.
Yeah, and also second part we did was when we were using it for so long, I always had a frustration that we could not take images or recordings on the computer or on the monitor. So now we put the screen we have is a computer and monitor built in one.
Mhm.
So we take pictures and recordings right off of the unit. So if you see something interesting, you just click a button on it, it'll record it or take a picture of it. And then we can use that information to share with other colleagues. And to insurance companies, whichever way we want to share the information, we can share it. So we have that capability as well.
Okay, Kristen, so tell us a little bit how you got involved with this, because you are very passionate about it, and we'll get to, yeah.
Yeah,
So,
so I've actually wanted to be a hygienist since I was 5 years old. So I went right into the hygiene program out of high school. And when I graduated, I was so eager to work. And I never forgot when I took perio, my professor said, "You want to work in a perio office." So for 1 year, I worked in general, and then a full-time position opened up with Dr. Alan Farber. And I started working in his practice, and he taught me everything I know about perio. He introduced me to the perioscopy, and I got trained on it. And he did not give his hygienist a choice whether or not they wanted to use it, which was the best thing, because being thrown into it, not having any choice, that's how I got really good at it.
mhm.
There's definitely a learning curve, but the more you do, the better you get. And after about 10 to 20 cases, that's when I finally had that aha moment of, I can never practice without this again. And just for diagnostic purposes, it's not just about removing calculus, but you're able to diagnose subgingival caries, excess cement, gutta-percha perforation, external root resorption, root fractures, things that you just can't see on 2-dimensional x-rays or 3-dimensional x-rays. And I was with his practice for about 4 years, And then I now work for Dr. David Scharf as a surgical hygienist only on Wednesdays. And we do every LANAP and LAPIP case together. So like Aziz said, no matter, you can be perfect, we're not all perfect, but we all leave behind calculus. And just a few weeks ago, I had a case where it would have been full mouth LANAP, but we did it with the scope. And I found a root fracture that I never would have seen if we just did it blindly. And this patient just so happened to be needle phobic. So I was able to show her the fracture and she said, oh, let's take it out now. So it's not just about, you know, taking pictures and videos, but being able to show that patient and then they're like accepting of the treatment, because now we have proof that it's fractured, as opposed to saying, well, it's 90, we know maybe 90% that it's fractured, or sending them back to the endodontist or the general dentist that did the crown. So while she was already numb, we were able to do the extraction the same day. And now that patient is thrilled. So I'm extremely passionate about this technology. And when I met Aziz, I immediately knew that. I said to him the first day I met him, I said, I want this to be my future. I'm not meant to do prophies or perio maintenance the rest of my career. I'm meant to train, educate, and be a surgical hygienist because I still do love what I do.
Excellent. That's you know, hearing you see the passion and the outcome of it, and so that leads me to why anybody in the. I mean, this is a tough question to say because I'm talking to two passionate people about that technology, but why people will want to do it? Why would they invest in it in their own offices? Because as you mentioned, Aziz, and we spoke that we can say without the title. So with all the respect to your title, but why would anybody, a periodontist or general dentist or whomever wants to do that, will buy it, since you know they can do scaling or planning, or they can promise them miracles with the laser. So what do you think it's important to implement it in the practice?
I'm going to break this down to two things. One being practical and one being what we do, what we're passionate about, our work. As far as periodontal disease goes, you know, the goal is always to get rid of the deposit from the root surfaces. You know, again, going back to classic literature studies and everything else, why we make flaps, so we can get access to it, we can clean it up and then close it up. So this gives us the ability to get access to the root surface without cutting open the patient, right? And we can clean out the root surfaces. Our medical colleagues have used endoscope for the last 20, 30 years, right? And they have minimized, you know, robotic surgery and everything else. They're trying to make the incisions as small as possible. We're way behind on the learning curve on that. And I think this is the technology that gets us to it. So we can make the surgery less invasive and predictable. Again, there's a lot of different philosophies on how do you treat it? You can treat it with a laser, you can treat it with biologics, or you can just clean it out. So I mean, this is it's also an art, right? What we do is an art, because everybody has their own little magic sauce of doing it. Whatever you want to do, you can do it that way. This is just an instrument to get the root surfaces clean without cutting open the patient. The second part, I'm going to the practical part, I'm going to financial end of it, right? This is super lucrative in the sense that again, we both have two hands, right? We can only see one person at a time, but I can hire multiple hygienists and they can be doing the treatment while I'm doing other things.
I guess you have an abundance of hygienists in Arizona. Here we're lacking. So can you send us some?
No, I actually disagree.
I know. I just wanted to tease you on that.
No, that's a really sour point. But the best part about this is it's not abundance, but I can pay my hygienist more.
Yes,
because they're producing more, and they have more skill sets than an average hygienist. And again, as Kristen said, like in my office, we have 7 hygienists. They do not have a choice. They have to do this, right? They have to learn how to do it. If you do not want to learn to do this, my practice is the wrong place for you.
Place for you.
Yeah.
So, you know, Kristen, I'm going to focus a little bit with Aziz here, because he's a periodontist. He grew up in the periodontal world of periodontists, and he knows very well that we are cynical. You know, it's and I hate that about our profession. Is not we question, we are cynical. We start with a negative before
Yes.
we hear the outcome, and that's something I tried when I was a director for training, to preach for my resident that cynicism should stop at the door, because you cannot advance without it. So for those cynicals,
Yes.
and they're so numerous, they're
Yes.
going to tell you, what are the proof in the literature? What
Yes.
is the studies? Blah, 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 same thing. So, and you know, and I know I can see you getting excited about it. I'm love that. I love that. Yeah, I love
And a
that.
lot of white hair, right? A lot of white.
No. I see it and I hear it. Look, I'm a big guy into innovation, and you know, Kristen, when she visited, she saw how much I have. But I'm just saying, I'm gonna
Agree.
put the devil advocate there, and
Yeah.
and they're gonna ask you these questions, and they're gonna be, you know, very. It's unproductive. I don't believe in cynicism myself, but
Yeah.
what it is. So they're gonna say, well, you know, I've been doing it without, you know, a scope. I've been doing that without the laser. You know, and look, the laser did not break through until they went through marketing. It's the same thing with everything. Innovation
Yes.
comes from marketing. Consumer
Yeah.
gets to know it, and that's how it comes. We are forced to use it, because if we
Yeah.
wait for the periodontists, they'll never do it. So, without any further,
Yes.
go ahead.
I think the two basic things. I again, like, to me, I'm like, it comes down to common sense in my head, at least. So, for example, all of us use magnification loops and lights, right?
Mhm.
I started in dental school with a 2.0. Right now, I'm at 4.5x with lights as bright as I can get it on my head, right?
Oh yeah.
I don't think there's a single study that shows it makes any difference. I don't think there is one. I would try to look for it. I couldn't find one. But we all use it. So we can't say, oh, I only do what is exactly, you prove.
Mhm.
And to me, with the scope is an instrument. It's not it doesn't solve every problem. It's an instrument in your armamentarium to use in places that you can use it. To me, I'm like, this is an instrument where I do not have to cut a flap, where I can get access to the root surface and clean it out. Once I clean it out, then it's up to me. Again, we're dentists, we like to fill holes. So we either fill it with a laser energy, or we fill it with a biologic like Emdogain or Gem 21,
Mhm.
whatever your preference is, right? And so I pick my cases on what I feel like, and I use those things. So cynicalism, like, yes, I think we all, because we've been trying to, people have been trying to sell us so many things. We
Mhm.
all get 10 reps every month, every week or month, to come into the door to, say, oh, this is the best bone ever. And the next week he's with a different company, this is the best bone ever. And we're like, okay, come on, guys.
Mm.
But this part is different, because it is an instrument that allows you to see. That's all it is. And once you can see, you will never go back. Like, Kristen said herself, like, once she did it, she goes, I will never treat any patient ever again.
Yeah,
I
but
put my money where
we're
my,
gonna get to that enthusiasm. I want it to be shared, because you know, when they look at dentists themselves, or with all my respect, I know who you are and how you are. Otherwise, I wouldn't be doing the podcast. But you're an integral guy. But a lot of people say, well, he has, if you know, he has created
yes,
something, he wants to sell it. Kristen has
yes.
no skin in the game, other than she's passionate about it, and she's helping when, you know, in the sales and all of that. So we will get to how she, as a hygienist, because we have two really in periodontics, without the hygienist we are useless, and we don't give them enough credit. And we will talk about the treatments that you think it is indicated for. So Kristen, you said, I saw a fracture, and you mentioned that to me, and you showed me phenomenal pictures, which is mind-boggling. But what else? I mean, the fractures is the percentage is limited. So let's talk about something more that you saw as a hygienist or as a provider, healthcare provider. What did you find in your result? Why do you are so passionate about it?
So I'm so passionate about it because, kind of like what Aziz said, is that if you're not getting 100% healing, there's still something going on. So for when I practice, if we don't get healing and we know that all the calculus is gone, then we go to, well, is there something systemic going on? So do they have uncontrolled diabetes? Do they have specific bacteria that they're having trouble fighting? So then we take it to the next level, and then we'll have the patient go for blood work. We'll do salivary testing or subgingival bacterial testing. But that doesn't happen often. And for the most part, getting all the calculus out, it resolves the inflammation. And the other thing too is finding other treatment. So not just root fractures, but I find decay at crown margins all the time. And you have this overgrown tissue, so there's nothing else that could be done
Correct.
other than crown lengthening. So then I'm also finding more treatment, not only for my boss, but then for the referring doctor. And because you can take pictures, you can take a picture of that, you can send it to the insurance company, and it actually helps to build your referral base, because then your general dentist loves you because you just found
Yes.
treatment for them. And for a general dentist, crowns are a big part of their practice.
I want to stay from marketing because I want to stay to the science, and I agree with you. But I have also some people that are patients that look for why this office has it more than the others, and why would I come to them? So you mentioned something extremely important. Now, we have fear of x-rays. We have sometimes you can't detect by x-rays, but here you're going with the scope, and you showed me those pictures where you can see the cavity and you see the intensity of the cavity. So the patient does not understand that what is it, the crown lengthening? Why would I need to go for crown lengthening? But here, if you show them how deep is that cavity under the margin that is close to the bone, because your picture was phenomenal, then that will calm the patient and educate them on the need for the treatment. And do you agree with me on that?
Yeah, exactly. And a lot of times, because of the material of the crown, it just blurs out the margin. So you're
Correct.
not
Yes.
able to see it. And then you take that picture, and the decay is a lot more severe than you think.
So, look, we have a difficulty finding hygienists in New York. I can't talk
That's
about the whole.
around the country.
I don't know how to talk about the nation, but I've been trying to hire full time. It's been a headache for me. So we do have not as many as you have, 7, but we have 6, and we have so we have one that is out for family leave, so that incapacitated me. So now I have 2. The need so it's difficult, and I
Yes.
understand. This is a profession that it gets boring. As Kristen told me, I don't want to do prophy all my life and stuff like that, or it's hard on the hands and so on and so forth. This kid brought them an excitement.
Yes.
That brought an excitement, that brought not only a results, there's no question about it, the results. I mean, look, you mentioned something very nice. And when we trained, and it was when I was training, we had to go through the classical literature between Loma Linda non-surgical versus New York surgical. So, and at that time it gained over is the surgical, because the accessibility, the cause of the disease, which is the calculus and all of that. So this is another alternative, not alternative, that's an extra layer to help us detect and remove the calculus, which is the cause of all our problems. So no question about it. I've been sold on that picture. So, but if you talk about a professionally wise for a hygienist,
Yes.
do you think that this can, other than the dentist themselves and setting them apart from others and so on and so forth, but do you think this is a good thing, Kristen, for hygienists to get excited about what they're doing and get more into this profession? What do you think?
I do. And the more people that I meet at dental conferences that we go to, it seems like it's a huge issue. There's a huge supply and demand of hygienists, and they're asking for a lot of money. And I think this kind of reignites our profession and gets us excited again about not just doing the same procedure all day, and it's not so repetitive. And I've always regretted not going to dental school until I got to the point in my career where I was really efficient at using the endoscope, and I kind of found my niche, and I didn't feel like I had to go to dental school because it's something that sets me apart from all the other hygienists. There's such a small percentage in the whole United States. There's about 1% of us that use this technology. And I think the more we get the word out there and the more people that use it, they'll feel the same way.
So since you mentioned before that you're involved in the training
Yeah.
and the support, so Aziz is the brain, so
Yeah.
he did that idea. Now he sits around, and now you are taking the lead on that. So what do you think? You mentioned multiple times learning curve,
Mhm.
how many sessions, and so on and so forth. Well, it can be intimidating, for a hygienist. So, what do you think? What's your feel about training? How you do it, and how good is it? How
Yes,
easy is it?
I was very intimidated when I first learned as well. So as I
I
mentioned,
doubt that you are intimidated, but that's fine, and I
maybe
appreciate
not.
your humbleness, but that's okay.
But it definitely took me like 10 to 20 cases to really feel comfortable. So when we come in to train, we start off by going over a PowerPoint, just describing each part of the unit, what it does, how to set it up.
Mhm.
And then we immediately jump into typodont training. It's really important that they get used to using the 4 explorers. So they're area-specific explorers, just like area-specific curettes. So there's 2 for the distal and 2 for the buccal, the facial, and then into the mesial and the lingual.
I've seen them. Can you tell the listener what is the probe? It's a very important thing.
Yeah, so the camera sits in the Explorer, which the tip then extends past the camera, and that's what gets inserted into the sulcus, allowing you to deflect the tissue back and fit your ultrasonic in front of it. So it's a two-handed, two-foot technique. So you'll use your ultrasonic in your dominant hand, you'll hold the Explorer in your non-dominant hand, and then your feet are used to make the water go. So for the Explorer, there's a very small drip of water that comes out, and that will clear the pocket of any plaque and blood as you're working. You don't always need that. It depends how inflamed the pocket is. Sometimes the ultrasonic is enough. So after we go over the typodont training, we jump straight into live patients, and we see patients for 2 full days.
Mm-hmm.
And we allow the hygienist to work on each quadrant so they get used to the different areas. And the first day is always rough. And I always tell them, you just have to sleep on it. You're going to feel so much better day 2. And they all do. They come in day 2 and they're so much more motivated. They're refreshed because you don't have that information overload. So we just kind of do a quick review in the morning and we dive straight into patients for the second day. But it's important to know too that we spend a lot of time with not just your hygienist, but the doctors themselves, the assistants, the front desk, because they all need to know how to talk to patients. So if the doctor is recommending this, they walk out and then they might ask the assistant a question. So we want everyone to really be on the same page. And we also teach you how to code, how to bill, and when to recommend the procedure. And I think my favorite part about the endoscope is that it's an in-between procedure. So sometimes the patient can't afford surgery and scaling root planing is not going to do anything. Or they're not at the point where they need surgery, but scaling root planing is just not enough. So then what do you do? So this really gives them that in-between option to still get really good surgical results without the need for surgery.
No, it's fascinating, and that's what I wanted people to understand. It's not. It can be intimidating at first because you are using actually everything in your body, your 2
Yeah.
hands and your
Yeah.
2 feet. So it's it's a paradigm change.
Yeah.
For
And
somebody to
yeah.
use everything. So it's not in it. It is, but it becomes a
You get
habit.
used to
Yeah.
it, and most hygienists haven't picked up their right and left ultrasonic tips since hygiene school, and
Yeah.
they're scared to use those. But truthfully, as I'm working, I can't not use my right and left tips. I can't reach that calculus that I'm seeing
Yeah.
with just your average tips that you use for a perio maintenance or even a scaling and root planing. And often, just to get to these difficult areas, especially around molars, I'm holding my Explorer from either the buccal or the lingual, and I'm actually instrumenting from the opposite side just to reach that piece of calculus. And I'm constantly changing my tips just to get it done.
You know, I mean, really, it's fascinating. Look, nobody will appreciate it until they see it.
Yeah.
I'm not gonna lie to you. When we spoke first and introduced me to Aziz and all of that, but until you came and visited, that was like the game changer in my mind. So, which brings me to the most difficult question, which will be the last. It's, we talked about cynicism and in dentistry, the terminology standard of care, it is so vague. I remember when I came to do a study when I was at NYU, we had two huge protocols for sinus lift and for an implant. And we were doing a CBCT immediately post sinus. Um, so we went to the IRB to the review at the medical center because that's where you used to do the IRB. And the question came, what is your standard of care about these things? And it took me by surprise at first. And people would say, well, it's science-based evidence. What's science-based evidence? And I had an argument with a very famous oral surgeon talking about allograft versus autogenous, because standard of care, golden standard, blah, 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 and all of these things. The reason I'm bringing it up is there's no really, and people are going to go crazy on me now, but that's the truth. So help me God, that standard of care is actually, it's us when we make it clinically or academician, or we create the standard of care. And standard of care in medicine is well established. In dentistry, it's vague. We know that when it comes to the non-surgical perio, you come as a patient, we do the periodontal charting, we do the scaling and root planning, we do the reevaluation. There's papers on when to do it, and the very close friends of mine wrote that paper. And 4 weeks, and then you redo the charting, and then if it doesn't work, you go to surgical. Now you're giving them another option on top of it. So bottom line, that's the only standard of care that we have. That is the truth.
Yeah.
Anything else? Yes. Everybody talks. You talk about regeneration, implant, peri-implantitis. Oh my goodness, who goes into crazy? Craziness. It's like in my hand and your hand, no, a golden stand, no, that's not going. So when it comes to standard of care, I think that you can't take the scope by itself and say this is the standard of care, which it is part of that protocol that I mentioned. The beauty of it that you have, and that is as a discussion we're having right now, is that when you look at the hierarchy of that, what I said, which we call it initial therapy. In the initial therapy, you are doing something so incredible with this technology that you did. You are increasing the results, the outcome. So automatically, in my opinion, this is not a question, is a periodontist or a dentist, a hygienist, or anybody who does that healthcare providing treatment for the patients in initial therapy, if somebody comes and tell them, I'm going to give you an instrument, and here I'm going to sound like a marketer for you. I give you an instrument, and that instrument is going to allow you to look under the gums, and you're going to see if you left any calculus. Would you say no? Obviously, you're not going to tell me no, but but I mean, if you put it in that perspective, instead of saying standard of care, who would say no? I mean, look, when I was younger and I used to teach pre-doc, I used to be an examiner for the nerves. There was few spots that you always fail them. And I want everybody to hear, those dental students to listen. This is the canine, mesial side of the canine. This is the side of the canine. On the CEJ, there is a concavity. The same thing on the premolar. Always they catch you there. So imagine, and that's very up high. imagine deep inside.
Yeah.
Premolar, first premolar, you have these beautiful concavities on the mesial side and the distal side of the roots. How can you see them with the blowing air? I mean, let's be serious here. So what you did is you gave people the opportunity to be able to see and detect the calculus on top of the other beautiful things, Kristen, the fracture, the cavities, and all of that. But if we go back to the fundamental of what we do day in and day out is to remove the plaque and preventive therapy. I think this is an amazing technology that anybody should be very grateful for you, Aziz, that you jumped on the boat and you put your money in it. You don't have any investors in it, so that's you. And I really want to commend you on it, and I say it from the depth of my heart. I am not, I'm not somebody, that give compliments easy. So it's fascinating. It's fun to meet people like yourself that come up with ideas. It's great to meet somebody like you, Kristen, passionate about what she does and do these things. And I hope that this podcast had brought more light and more introduction to this beautiful technology. I can't wait to have it also myself in my practice. But it is really fascinating, and I want to really thank you, not only to get me the time and come and meet with me and do the interview, but also for this, for your idea. It's brilliant. Really, thank you, Aziz. I really,
I'm gonna one little thing, Echo.
Sure, it's all yours now.
It's not my idea. We have a little thing like, we stand on the shoulder of giants. This is not me. I stole it from somebody else, right?
Well, you did not give up on it when
Yeah,
Zest
I
didn't
didn't
give up.
give up.
Yeah,
Yeah,
I have to give you
but-
the credit on that. Yeah.
But I owe my practice changed after I met John Kwan. Dr. Kwan, he's an amazing human being, amazing what he was able to save the technology beforehand. I feel like I took the baton from him and carrying on, but it wasn't for him and people before him who did this. They put a lot of time and effort into bringing this. I'm just taking them and making it better, a little bit better, right? And doing my part to it.
I appreciate your
And-
modesty. Yeah.
And no, because
No, it's true. It's true. It's very nice. That's very nice. of
those
you.
guys put their lifetime into it, and John is so amazing. We still connect with each other. He helps us out. I go to him for advice and everything else. So it's great, and I love that part of our community that we have those people that are willing to share their ideas and their thoughts and
Yes.
everything. It's great.
Yes. That's amazing, and you're right. We have to give the credit where the credit is due, and that shows how much you are a wonderful person, and that's commendable. A lot of people forget who came before, so that is one of our other problems we have in our profession. So I want to really thank you both. I want to thank you, Kristen, for poking me, and we ended up meeting you all and introduced me to this technology. I really appreciate it. And thank you, Aziz. And I wish you all the best, and to the next time.
Oh, perfect. Thank you Evan, for
so
having us.
much.
Yeah,
Thank
my
you.
pleasure. Take care. Have a wonderful evening.
You too.
Bye-bye.
Bye.